We'd like to now call up our next set, and that's Dr. Emma Gutman, who is well known to us as a professor of dermatology and immunology and director of the Center for Excellence in Eczema at the Mount Sinai Icahn School of Medicine. She's really very comprehensively identified the molecular basis of the immune pathways in atopic dermatitis. And she is coupled with Frank Nestle, who's currently the global head of immunology and inflammation research therapeutic area and North America chief scientific officer at Sanofi. But he's coming today because of his previous life, where he very comprehensively defined the immune pathways in psoriasis. So we thank both of them for sharing knowledge with us today.
Thank you so much, and we are both very excited to be here. I actually met Frank and became friends with him in 2005 when I joined Rockefeller University, and he was doing a sabbatical there. So very exciting for me to do it together with Frank, a giant in psoriasis.
Yeah, and so returning the compliments, you know, when I met Emma in her early day careers at Rockefeller, I could already see the Kane sign of being a future star in the field, and I'm glad that this has happened and that I can share sort of some of the wonderful science she has produced and some of it we have produced together. Excellent. So just in terms of disclosures, I probably should say that since September I'm working for Sanofi. It's an amazing experience. I enjoy every single day. But believe me, we had a Chinese wall for any dupilumab data we're going to talk about. So I have no clue what she's going to say about dupilumab, just to say that. But there's really the overarching conflict of interest, which is not on that slide. And this is the marching orders we got from Amy, including a one-page email last Sunday, which actually clearly told us what we had to say and what we couldn't. And that really includes what are the similarities between psoriasis and atopic dermatitis. And this is really sort of the main focus of the talk. Excellent. So overview, atopic dermatitis and psoriasis are really reversible. That's wonderful for dermatology. You know, we are never at a point of no return. And that's what, you know, sort of matching our insights into mechanism with these targeted therapies, we know we can go to the patient, can say, you know, there's not a point of no return, we can go back. So there are immune-driven diseases, and there's quite a lot of similarity, not only in terms of the specific tissue inflammation, but also in terms of, you know, are any of these diseases more than skin deep? And we're going to discuss that in terms of comorbidities. And then finally, what about non-lesional skin? We have this unique opportunity in dermatology to not only look at the pathology, but also what's happening in non-involved skin and compare that and contrast it, and we're going to discuss that. And finally, what about phenotypes, subtypes, ontology of disease, and we're going to give you an insight into how psoriasis and AD might differ, but also where the similarities are. Now, let's start with the basis. This is when I sort of started off in dermatology, and I said the pathophysiology of dermatology comes from histopathology, and if you look at the two top rows, from the back, you could actually say, look, these two diseases, atopic dermatitis and psoriasis, are not really distinguishable. Both in certain stages of disease have really pronounced acanthosis, elongated rete-ridges. Both have disturbances of keratinization. Both have a proliferation-associated keratin expression, which is keratin 16. Keratin 16 is sort of this inflammation-associated keratin. If you see it and it's switched on, disease is really active. And if you have a good drug and you do a biopsy, it's switched off. It's like going a light on and off. And you can see that this light, in terms of inflammation, is on in both atopic dermatitis and psoriasis. And if you look at the level of proliferation reflected by Ki67, both diseases are highly proliferative. Now, obviously, there has been a slight bias in selection, because what we selected for the atopic dermatitis is really a chronic, heavily infiltrated piece. I could give you an early atopic dermatitis slide with a lot of spongiosis where this would be not as impressive. But you can see there are a lot of similarities on the histopathology level. Now, what about immune infiltrates? And you see to the left normal, in the middle atopic dermatitis, and to the right psoriasis. And you can appreciate that both diseases really have not only a pronounced infiltration of effector T cells in the dermal compartment, but also in the epidermis. So there is this crosstalk between the immune system and the epithelium at multiple levels, and that's what we're going to dig down to in a bit more detail. Now, what about cytokines? All these mediators and of inflammation, which we can measure in atopic dermatitis and psoriasis. And both diseases went through their fair share of sort of paradigm changes. Psoriasis sort of started off first as an epithelial disease, then it was a Th1 disease, and now we're believing it's a Th7 disease. Who knows what kind of T cell we're going to discover and what psoriasis will be, but my bet would be we're keeping calling it a Th7 disease, and you can see that on the left side in terms of multiple mediators related to that pathway. What about atopic dermatitis? Its fair share of paradigm changes. It was considered a disease mediated by mediators of the arachidonic acid cycle, leukotrienes. It has been considered a Th2 disease, then again thought of as a Th1 disease in certain cases. Now we have fundamental proof from the clinic that it's truly a Th2 disease. But what other cytokines might play a role? And Emma is going to give us an insight into sort of the multi-possible phenotypes of atopic dermatitis. Now, what are the effector cells mediating major immune pathologies? And they're really classified in a very simple nomenclature. There are Th1 cells, Th2 cells, and then Th17 cells. Th1 cells, which essentially protect us from pathogen infections, especially intracellular pathogen infections, really they're still on the lookout for a true mission and a true pathology, but I can guarantee you it will come at one time. Then we obviously have Th2 cells, and they're sort of driven by very important epithelial alarmins, TSLP and IL-33, and really are able to secrete these important Th2 effector cytokines, IL-4, IL-13, which lead, among others, to class switching of B cells and production of IgE. And then we have the Th17 axis of immunity with IL-23 as the major upstream mediator, which actually turns pre-committed Th17 cells in tissues in the presence of IL-23 coming from dendritic cells into true pathologic effectors. And obviously IL-17 is a key cytokine. But there are also other shades, and actually in this case, red and blue kind of gave this kind of violet or purple box, where Emma is going to tell you that, for example, in atopic dermatitis, there are so-called Th22 cells, which might play an important role in disease. So it's not all like blue and red. Some might be purple, and some of these effector pathways still look for a mission. Now, how did our sort of whole perspective in dermatology start out in terms of really being, in dermatology and inflammatory skin disease, a role model for actually dissecting molecular pathways at the cellular level, but also at the level of communicating between cells via cytokines and using that as sort of a druggable approach. So really doing rational therapy, and psoriasis really can probably take a credit for a lot of the paradigms which we are now using to essentially study disease, not only in skin, but also in the gut, in the lung, and also in the joint. And here is a scheme, essentially what puts dendritic cells in the center of the action, because the dendritic cell is the sentinel which can actually take cues from the innate environment, and this includes cells from in the epithelium, but also innate immune cells, including NKT cells, macrophages, and plasmacytoid dendritic cells. And depending on those cues, become activated and then actually turn on what is really the important effector arm of our immune system, which is the adaptive immune system, which has memory, specificity, and actually is very active, not only in protecting us from pathogens, but as we are seeing, and that's why we are here, creating trouble for our patients. And it's really Th17 cells and Th22 cells together, which then in crosstalk with keratinocytes create trouble via the secretion of multiple pro-inflammatory cytokines, chemokines, which sort of get this vicious circle into motion and create chronic tissue-mediated pathologies, including in the skin, in the face, in terms of psoriasis or atopic dermatitis. Now, we had a beautiful talk and actually a delicious even talk about genetics. And this is my one sort of genetic slide. Kurt, I have to mention Francesca Carpon as a main contributor to this conceptual idea. But essentially what it tries to do is put the IL-23, IL-17 pathway in the context of genetic variants which have been associated with either disease susceptibility or protective function to disease. And you can see that in the lightly shaded molecules here, both the heterodimer of IL-12B and IL-23, the IL-23 receptor, very interesting JAK kinase, TYK2, adapters of IL-17 signaling, and then positive and negative regulators of NF-κB, as we heard in the previous talk. Now the interesting element is really that if we think about the drugs which are either in the clinic or on their way to the clinic and really have already provided substantial sort of clinical footprint either at the bedside or in clinical trials, then it's amazing how if we map these genetic variants onto a pathway such as IL-23 and IL-17, how these drugs are really kind of pointing to very important points. And I can tell you that probably in the future we see more drugs along this pathway potentially coming next to a patient near you. Now, how does the IL-17 pathway really play out in the epithelium? And this is the $100 million question. We heard about the importance of essentially the epidermal barrier, but it's not only the disruption of the epidermal barrier, it's that the epidermis is fundamentally a pro-inflammatory organ. And if you think about a very simple entry into thinking about this by a dendritic cell producing IL-23 and actually switching this pre-committed Th17 cell or actually innate a cell into an IL-17 producer, then we have an action both on neutrophils, linked with neutrophilic infiltrates, typical in psoriasis, but also, probably more importantly, an important alarm signal for the epidermis, which then leads to a secretion of a variety of pro-inflammatory chemokines, cytokines, and growth factors. But there's also the IL-17 of the epithelium. There's an IL-17 of circulating immune cells, IL-17A and F, but there's the IL-17 of the epithelium, which is IL-17C. We have not seen much about this, but it's a very interesting cytokine which can, in an autocrine manner, actually act back on the epithelium. And we have other IL-17 family members, including IL-25, IL-17E, which need further study to really understand how they are fitting into this pro-inflammatory picture. Now, coming back to the IL-23, IL-17 axis, this is another depiction now moving away from genetics, but looking at the fundamental key cytokines. And for me, having started on this journey in the 80s and having witnessed how we moved from essentially a pathogenetic talk just at the beginning of the meeting, and all the clinicians were saying, well, what is this really doing? We cannot do rational drug therapy. If we look at this picture, that clearly, in my mind, establishes the principle, which we are now seeing playing out. And I think we will hear in the therapeutic session much more about the specifics, about the specific capabilities of these drugs to make changes in patients. So I'm handing over, finally, to Emma.
So I think it was very important to hear the story for psoriasis, because I think in atopic dermatitis we are following the footsteps of psoriasis. And in fact, when I started in atopic dermatitis in 2005, things were really not clear for atopic dermatitis. It was not clear what do we need to target. Do we need to target the barrier, as we heard, or we need to target the immune system? And what is becoming clear now, that we really have a paradigm shift in the pathogenesis of atopic dermatitis. Because it doesn't really matter what starts first, if it's the barrier or if it's the immune abnormalities. What matters, and that's a very key point, is that the perpetuation of atopic dermatitis and moving from non-lesional skin to chronic disease is due to increases in cytokines. And that's why you heard there are now approaches to prevent atopic dermatitis, and they are targeting the barrier. However, once you already have the phenotype of atopic dermatitis, you have to target the cytokines or the immune abnormalities. And that's a very important consideration. So what do we have here? We have cytokines that increase already at the non-lesional skin. That's a big difference from psoriasis. In psoriasis, the non-lesional skin is much closer to normal. However, in atopic dermatitis, how do I activate the...
You just can use the pointer here. Yeah, so here, just move the pointer. I can move the pointer for you if you want.
So we have cytokines that already increase in the non-lesional skin, and that process is increased or amplified in acute disease and even more in chronic disease. So what cytokines we have? We have the Th2 cytokines, IL-4 and IL-13, that inhibit antimicrobial peptides, and there is very important research from Donald Leung showing that these antimicrobials are decreased in atopic dermatitis, and we show that they are actually increased in psoriasis, and we need to remember psoriasis patients do not have infections, whereas patients with atopic dermatitis have infections. And the same IL-4 and IL-13 inhibit barrier proteins such as filaggrin that you heard about, and many others, loricrin, involucrin, and also lipids. We have the IL-31 that also is derived as a Th2 cytokine and starts the itch scratch-like unification cycle. We have IL-22 that we described back in 2009 that starts the hyperplasia in atopic dermatitis, also disrupts the barrier with decreases in filaggrin, loricrin, and involucrin, and also synergizes with IL-17 that is so important in psoriasis to produce the S100s. And this process is, again, amplified in chronic disease and has a very important relevance to treatments that are being developed right now. So how do we test the immune hypothesis that I put forward? A prediction of this model is that immune suppression will be able to reverse the epidermal pathology we now have in atopic dermatitis. This hypothesis will be rejected if immune suppression is achieved, but the epidermal phenotype of atopic dermatitis is persisting. And due to time, I will show you only one proof of this hypothesis using dupilumab, that is an IL-4 receptor antagonist. And I like to always start with this first proof of concept study that was a phase 1b study, was actually designed for safety, but luckily had mechanism, and I think it's a nice first proof of this hypothesis. This study was a small study, only 67 patients across several continents, a 4-week study in which injections of 75 milligram, 150 milligram of dupilumab, and 300 milligram and placebo were given, and luckily 18 patients participated in a biopsy sub-study. Now, the results were already significant by week 2 in the 300 milligram group, and even more by week 4. It was clear-cut that there is dose response here and the treatment was effective. Importantly, there were no differences in responses of patients between patients that had high Ig level and patients that had low Ig level, and also patients that had filaggrin mutations and patients without filaggrin mutations, and that is important. Now, my lab studied the molecular changes in the disease with dupilumab. For that study, we did not have immunohistochemistry, but as you heard from Frank, keratin 16 is a very good marker of epidermal hyperplasia or epidermal proliferation. And we got a dose response here as well. We did not have 75 milligram. We only had dupilumab 300 milligram biopsies from patients that were treated with the 150 milligrams, and biopsies from placebo. And this is a logarithmic scale. So in dupilumab 300 milligram, we received about 10-fold change decrease in keratin 16, about 2-fold change decreases with the 150, and in placebo, we actually got an exacerbation, and that was surprising because we all know the high placebo responses we usually have in atopic dermatitis. This is why it's so important to do these tissue studies, because in tissues, we actually got an exacerbation. On the left side, you see a heat map of many markers we performed by real-time PCR, And we looked at multiple axes. We didn't look just at the Th2 axis. We wanted to see what happens with other axes. And we were quite surprised. And blue is suppression or downregulation. Red is upregulation. You can clearly see marked suppression of markers in the 300 milligram. Whereas you see in placebo that there is upregulation of many markers. And these go far beyond the Th2. So yes, we did receive, as we expected, reductions in the Th2 axis, including the chemokines that are very important in the Th2 axis, CCL17, 18, 22. But look at that, we have reduction in IL-23A. This is P19. And S100 that is induced by IL-17 and IL-22. And many others. So dupilumab really reduced many markers, and you will see the same in a phase 2 study that we will publish later on, hopefully this year. And I want to show you from this larger phase 2 study. It was a phase 2 mechanistic study that we did, that we now prepare the manuscript. And this study actually did have immunohistochemistry, was also a longer study. It was 16 weeks. And we had biopsies at baseline, at 4 weeks, and at 16 weeks. And it included 54 patients, 27 patients on placebo, 27 patients given drug. And here you can clearly see reduction in the epidermal hyperplasia, really major reduction with dupilumab. In fact, at week 16, the lesional skin looks very similar to the non-lesional skin. And the keratin 16 that is so important to show that the disease is turned off, as you heard from Frank, entirely disappears in dupilumab-treated patients, whereas it's still maintained in placebo-treated patients. And we also looked at filaggrin. Filaggrin is a very good marker to see how is the barrier reversed. And usually, we see in patients with atopic dermatitis in lesional skin skipped expression of filaggrin, whereas you want to see a nice continuous line of filaggrin, which is what we see at week 16 with dupilumab, but not with placebo. So we have reversibility of the barrier with dupilumab, and we do not see that in the placebo patients. When you look at the epidermal thickness, you see that the median change with dupilumab is more than 40%, whereas you do not see that with placebo. So I hope I convinced you that dupilumab impacts both the inflammation but also the barrier dysfunction that characterize atopic dermatitis. And I think this establishes IL-4 and IL-13 as pathogenic cytokines for atopic dermatitis. But more importantly, I think this cements atopic dermatitis as immune-driven and reversible, very similar to psoriasis. We did not have such a proof before, because we did try to show it with other studies like cyclosporin and narrowband UVB, but these affect the epidermis. So it wasn't a final proof. This is the first final proof that atopic dermatitis is immune-driven and reversible.
All right, thank you very much, Emma. We're now going to shift gears a little bit and actually moving to a question is these sort of skin inflammatory phenotypes we described, are they more than skin deep? And I guess, again, psoriasis sort of was setting the scene in terms of making the case. As clinicians, we always knew that we had patients with psoriatic arthritis, and about 20% of patients, nail psoriasis is quite prevalent. But I think the fact that up to 50% of these patients suffer from metabolic syndrome with dyslipidemia, insulin-resistant diabetes, obesity, arterial hypertension, then as deadly quartet, leading to sequelae such as stroke and myocardial infarction and death. This was unappreciated. Joel Gelfand in the audience here and others really have kind of made the case that this is a very important contributor to the overall pathology, and I think there will be much more to come to understand how really local inflammation is kind of playing out in the context of systemic inflammation, cardiovascular sequelae, and how we ultimately are in a position to drug this. Now, I just show you one data slide which sort of compares severe psoriasis and AD. We would all subscribe, and this is from Knut Krökwal's group and published in 2015, we would all subscribe to the view that psoriasis can lead to these kind of severe calcifying events and in key cardiac vessels, and this is shown with a cardiac CT plus angiography. But if you look here in psoriasis in blue, and AD in red, and here you see the percentage of essentially arteriosclerotic segments in the heart of patients, you can actually see multiple things. One is, if you compare it to controls in green, there's more atherosclerosis going on in heart vessels than in heart vessels of inflamed skin patients than in controls. But what's really interesting, that this is also playing out in mild disease. So really it's mild disease, already patients with mild disease who have a lot of these features, and that actually AD really stands up to psoriasis in this. Now, this is not really any epidemiology would say, like, what can you do with this data? This is just sort of making an argument here that AD really is also a systemic disease with multiple potential sequelae, and Emma is going to drill down into this a little bit now.
Yeah, so we have very exciting data that atopic dermatitis emerges as a systemic disease, and I think the future years will show it much more. And it's important also to see how the treatments reverse that systemic disease effect of atopic dermatitis. Now, this is a paper from the International Eczema Council. This is the first paper actually that we did as a group, in which we looked very deep into the emerging systemic abnormalities of atopic dermatitis. And we saw that there is an increased evidence of cardiovascular disease. A lot of the data comes from Jonathan Silverberg, but also others, infectious manifestations, neuropsychiatric, and other comorbidities in atopic dermatitis. And this is in addition to the known allergic or atopic manifestations, because these were known for a long time. Now, this is a meta-analysis that was done by my own group, in which we took all the published molecular transcriptomes of atopic dermatitis, and we put them together into a robust disease phenotype in tissues, robust transcriptome. And we were quite surprised, and I can tell you that the psoriasis meta-analysis did not show it actually as a top pathway. We were very surprised to find the atherosclerosis signaling actually being represented really at the top in atopic dermatitis. Now, here is the place to ask, what is the level of systemic inflammation in atopic dermatitis versus psoriasis? And of course, each one versus their own control. But for psoriasis, as you heard, we now have quite a lot of evidence that there is systemic inflammation. A lot of data from Joel Gelfand and others really put this very nicely forward for psoriasis. What happens with atopic dermatitis? So both atopic dermatitis and psoriasis are characterized by T-cell activation in skin, but their comparable systemic T-cell activation in blood was really unclear. So my group set up to evaluate this. And what we did, we evaluated by flow cytometry T-cell activation markers, ICOS, that is a mid activation marker, and HLA-DR, a late activation marker. And we did it in both central and effectory memory skin homing cells. In both skin homing cells that are marked by CLA positivity. CLA is cutaneous lymphocyte antigen positivity, a very good marker for cells that home to the skin. And CLA negative, or I like to call them the circulatory cells that stay in the circulation and do not home to skin. And we did that in both atopic dermatitis controls, and together with Jim Kruger in a collaboration, we also looked into psoriasis. And we were quite surprised by the findings, because we saw that atopic dermatitis doesn't have just excess T-cell activation compared to controls, but it also had T-cell activation increases in the circulation compared to psoriasis. Now, psoriasis, and that's for all the markers of activation, both ICOS and HLA-DR, and in both CD4 and CD8 cells, psoriasis actually was higher than controls, but atopic dermatitis was very significantly higher, not only compared to controls, but also compared to psoriasis. Now, we also, and this is a recent publication that we have in GID, we also looked at circulatory cytokines and chemokines in the serum, and we looked at a panel that included Th1, Th2 markers, and also IL-22. And we saw really high increases in the serum in these markers. We have here IL-22, IL-13, and several chemokines from the Th2 pathway. But very importantly, these markers were not just increased in the serum compared to controls. they were highly associated with SCORAD. So the increase was highly correlated with the increase in the SCORAD. So the more severe patient you have, they will have higher increases in these circulatory markers. And why is this important? In another study in which we treated patients by cyclosporine, we evaluated the same markers. And we saw decreases in these markers, and not only we saw decreases, the decreases were associated with the decreases in disease severity by SCORAD. So we need to ask, are these modifiable risk factors that we can evaluate in blood? Now, we all know by now that the non-lesional skin of atopic dermatitis patients is abnormal, and I think the systemic immune activation that we have in atopic dermatitis is reflected in the abnormalities in non-lesional skin that you can see here. So already in non-lesional skin, you have activation of the cytokines, the Th2 and Th22. You have increases in IL-13 and the chemokines CCL17, 18, 22, and many chemokines of the Th2 pathway. And you have increases in Th2, IL-22, and the S100s. So the non-lesional skin of atopic dermatitis, even though it looks normal, maybe it's a little bit dry, it's not normal. And that is due to the systemic cytokine activation. So I think I managed to convince you here that atopic dermatitis does emerge as a systemic disease with high-grade systemic immune activation that we have of T cells, circulating cytokines, and I didn't have time to show you, but also B cells. And I think this is the common denominator that leads not only to the allergic or atopic manifestations, but also to other comorbidities that are emerging, such as cardiovascular, infections, and others. And this has very important therapeutic implications because you cannot treat patients with severe disease just with topicals because you have systemic immune activation, their non-lesional skin is defective. So this really emphasizes for severe patients the need for systemic treatment approaches. Now we'll switch gears and we'll ask, and this is a big passion of mine, is atopic dermatitis a single disease or the same phenotype? We know that psoriasis is quite homogeneous. Is the same in atopic dermatitis, a disease that has several variants that have been described, acute and chronic, intrinsic, patients with a normal IG versus extrinsic, high IG levels, pediatric versus adult, filaggrin positive, filaggrin negative, and what about Asians and European Americans or Western patients? And why is this so important? Because if it's a global disease phenotype, it will imply that similar treatments apply for all. If these are different phenotypes, they might require different therapeutic approaches. So the stratification of atopic dermatitis phenotype might be important for developing a personalized treatment or personalized medicine approach for atopic dermatitis. I don't have time to go into all the phenotypes, but I want to show you my research on Asians' atopic dermatitis compared to European American. And this study was done jointly with my friend from Japan, Kenji Kabashima, and also Kwang-Hoon Lee from Korea. So what is the idea behind this study? Although comparative data were not available at the time, there were some observations that suggested that Asian atopic dermatitis may be different than European American atopic dermatitis. First of all, there were some reports about differences in the clinical phenotype. As you see here in this representative picture, Asians have more well-demarcated erythematous plaques, a little bit more similar to psoriasis, whereas in European Americans, we know it's blending with the surrounding. There were epidemiological differences. In the United States, we are talking about 3 to 7% of adults, and that's a high estimate. But in Asia, there are reports up to 10% of the adults in Asia and around 25% of the children in Asia. And very importantly, I kept seeing repetitively studies from Kenji Kabashima's group showing increases in IL-17 producing cells, both in skin and blood. And in fact, I did not replicate this data in my own European American patients. So thus we did a study in which we compared 27 Asians that were from Asia, from Japan and from Korea, to 25 European Americans. And what is important here is that all the Asians, besides one patient, had very high increases in IgE with a pre-identified biopsy of atopic dermatitis. And that is important because when we saw this data, we were really struck. The Asians, many of them had real features of psoriasis, including vastly increased hyperplasia, much more than we see usually in atopic dermatitis in European Americans, with parakeratosis that usually is not a feature that we see in European Americans, and focal hypogranulosis. And when we looked at the epidermal thickness of all the patients, Asian is in blue, European American is in red, we saw increases in the thickness, not just in lesional skin, but also in the non-lesional skin of Asians. So what happens with the immune pathways? In Asians, we see similar Th2 activation. As you see here, IL-13 is not there in psoriasis, as we already heard. Psoriasis doesn't have a Th2 pathway. The Asians and European American AD did have increases in Th2 axis, maybe slightly less in the chemokines, but overall the same picture applied for the Th2 axis. However, when we evaluated Th17 and Th22 axis, we saw that the Asians were an in-between phenotype with increases in IL-17 compared to the European Americans, not as high as in psoriasis, but it was certainly increased. The same with IL-19, a cytokine that is associated with IL-17, and the same with IL-22, and the chemokines. They all showed a trend of increases in Asians. And when we did an unsupervised clustering using a principal component analysis, the red is marking the Asians. The Asians were really in between European Americans and psoriasis, and in between phenotype. And that may have some relevance to treatments. So importantly, all the atopic dermatitis subtypes are characterized by T-cell activation, and that T-cell activation is setting up the epidermal responses. But some subtypes also show differences in their immune profile and might necessitate different treatment approaches, including those that are applied now so successfully to psoriasis, IL-23, IL-17, and IL-22. I don't have time to go much into it, but I want to show you a few studies. Yeah, I'm at my last slide, last 3 slides. So I promised to do it.
I have it in writing that I warned her.
No, I'll do it very quickly. So this is a study we did with ustekinumab. Ustekinumab is a treatment available for psoriasis for a long time, anti-IL-12, IL-23. It was not so well designed as we understand now because it was a crossover design of 32 patients that were crossed over at week 16. And 16 patients started with ustekinumab, 16 patients started with placebo. Another factor here was that we gave patients jars of topical steroids. We now know that it's a no-no in atopic dermatitis studies, and that probably affected the study. And another caveat here is that we use psoriasis dosing. I showed you that atopic dermatitis patients have much more immune activation, so psoriasis dosing is not enough for atopic dermatitis. But nevertheless, I think it does show a trend of efficacy, because if you look, the group that started with ustekinumab in the beginning, they improve quite a lot. Then they probably did not give their dose that they should have gotten here, and that's why they have a decline. But they maintain their efficacy. At week 40, you have 50% score at 50 responses in the group that started with ustekinumab, and I think that is still impressive. But I think definitely we need other studies. This was not at all definitive. And I want to show you briefly that it does reverse actually the molecular phenotype. When you look at week 32, there is a reversal of the phenotype in the group that started with ustekinumab, and already by week 4, you see changes in that group. And interestingly, some of these changes are reduction in Th2 markers, and that we need to understand some more. And we have an exciting study with an anti-IL-22 that we will present later on at the SID. This is a representative patient with very lichenified lesions, and this is how she looks 3 months after. And I will give you a teaser. It's a positive study, at least in a subset of patients, and we will present it later on at the SID. Sorry about going over.
Thank you very much. I'm going to be very brief. You can read a summary for yourself. I just would like to say thank you very much, Emma. It was fantastic to be on stage with you. I hope to be repeated. Thank you very much. Thank you.